thank you all for joining. We have a full webinar planned with actually 4 of my colleagues presenting from all over the United States. We have Dr. Hurwitz from Duke University Medical Center, Dr. Shearer from North Carolina as well, Dr. Rabat from Loyola in Chicago, and Dr. Raff from William Beaumont. So thank you in advance to my colleagues for being willing to take the time to put together presentations to share with you their clinical experiences. We thought it was apropos for this, our third educational webinar, to focus on interpretation of FFRCT and lessons learned from the many, many cases that have been undertaken at their respective institutions, particularly given the introduction of the new release of the report structure by HeartFlow that will target, I think, dealing with a number of the issues that we'll discuss this morning. I'd also like to thank HeartFlow for providing the platform for this educational opportunity and for the opportunity to share knowledge. The cases have been selected with the goal of really engaging with a broader group here on the webinar with regards to conversation and dialogue. Our thinking was that we would ask questions likely at the end, although if organically questions come up, please don't hesitate to ask. Obviously, we want to try and find teaching points, not in the cases, not only those that are identified by my colleagues and by myself, but ones that you may in fact see that relate to you and your practice, and some important information and ways to improve the integration of FFRCT, the utilization of or the interplay between coronary CTA and FFRCT, and again, of course, always with the focus of improving the care for the patients that we're serving. So without further ado, the first presenter is going to be my colleague, Dr. Hurwitz from Duke University Medical Center, the future national champions.
Great. I'm just going to go through a case that I thought was rather interesting and highlighted a couple things to me about clinical interpretation reporting. So this was a 67-year-old obese Caucasian woman. She was 213 pounds and 4'11". She has a history of hypertension and hyperlipidemia and came in with a recurrent complaint of chest tightness and heaviness. Her past medical history was notable for a nuclear stress study 1 year prior that showed no reversible segmental perfusion defects. And on the recommendation for follow-up and imaging, the patient was adamant to not undergo any invasive testing. So a cardiac CTA was selected as the imaging modality for choice. So this is a scout film of this woman. The image acquisition, she had a heart rate of 78 that was regular during the study. Because of the heart rate, we used a retrospective acquisition with minimal dose during systole. This was performed on a dual source third generation multi-detector scanner with a 66 millisecond temporal resolution, 60 mLs of IsoView, and she had received 100 PO of metoprolol an hour prior to the study, and received 0.4 sublingual nitroglycerin before image acquisition while on the scanner. So I just wanted to go through her anatomic images. These are the CPR and the 3D volume rendered images of her right coronary artery, which showed very nice vessels, no atherosclerotic disease, no luminal narrowing. Similarly, for the circumflex distribution, the proximal and distal circ, and the obtuse marginal and branch vessels. But the area of abnormality that was pointed out was really related to the LAD circulation, where we've got mixed but predominantly calcified plaque in the proximal LAD, and then more significant area of disease involving the distal proximal LAD at the D1 bifurcation, where the narrowing was of higher concern. So this final anatomic read was interpreted as a 50 to 70% narrowing of the proximal LAD and ostial D1 with calcified plaques and a CAD-RAD score of 3. We subsequently sent it for FFR analysis using this data set. And this was, these are saved images from the PDF and the interactive viewer that was sent back to us. So this is a laid out 3D model from the FFR model and the summary table that came with the FFR. And so it's easy to see that the proximal portion of all the vessels, the FFR values from the CT stay above 0.8. But then when we look at the table, our eye naturally will come to the area of reduced and lowest FFR being in the LAD circulation. So it's really important to correlate the FFR values with the anatomic images, and I think this case illustrates that. You could see here when we put together the anatomic images with the 3D rendered image from the FFR analysis, we could see that in the proximal LAD and the osteal D1 regions where we had anatomic luminal narrowing, the FFR values do not significantly drop, a minimal drop of about 0.03. But distally, we have notable mild decrease in the FFR values to just below 0.8, particularly in the distal LAD, but there's no corresponding anatomic stenosis. So the summary then is a proximal LAD and osteal D1 narrowing that's not hemodynamically significant and not flow limiting, but a slight reduction in the FFR CT values in the distal LAD and D1 without anatomic narrowing. So just to point up for discussion, I think that the FFR CT brings up both an opportunity and a challenge for us with coronary CTA interpretation. The challenge being that it's a little bit more data than maybe we would have from an invasive FFR value, and that it also needs to be not read in isolation. You need to read it with the CTA anatomic data set. But the opportunity being that we often get a lot more information than we maybe would with an invasive value. So while it may be easy to report out here, or the initial feeling to just report out a reduction in FFR in the LAD distribution is significant, by looking at the anatomic images with the 3D model and interrogating it ourselves, we can make sure that we're reporting out the correct drop in the FFR with the correlation to the anatomic imaging. And I think HeartFlow has done a really nice job in changing over their PDF now to make this easier for readers, with a summary table at the beginning noting that the FFR values will be reported at areas where there's 30% luminal narrowing, as well as the distal aspect of the modeled FFR analysis. And I think this will help both readers and referring physicians look at both the anatomic areas as well as have a better understanding of overall physiology along the entire length of the coronary arteries. So in summary, this is a patient with proximal anatomic narrowing that's not hemodynamically significant, but a slight reduction of FFR distally without anatomic luminal narrowing. So patient recommendations were for medical treatment, and the discussion being that the reduced FFR was probably related to some component of underlying microvascular disease or a volume to mass mismatch. And that's where I'll finish.
Thank you. Yeah, interesting case, and I think the whole discussion around actionable disease versus abnormal pressure loss in the distal territory will be fodder for good discussion at the end. So why don't we move on with the next case? Keep in mind our questions that we'd like to ask you, Lynn. Thank you again for the presentation. I believe next will be Dr. Rabat will share a case with us from Chicago.
So I have a 74-year-old female with hypertension, obesity. Her BMI was around 40, presenting with stable chest pain and dyspnea on exertion. Prior to her seeing me, her PCP had ordered a regadenoson nuclear stress test, which was negative. There was normal myocardial perfusion without any EKG changes. So I went ahead and ordered a cardiac CTA with her symptoms. And focusing on her LAD, you can appreciate on this multiplanar reformatted image that there's multiple lesions in the left anterior descending artery, prox, mid, and distal, both calcified and non-calcified in nature. Here's another image of the left anterior descending artery here, proximate and all the way extending distally. So based off of these anatomic findings and the patient's symptoms, many would go on to proceed with invasive coronary angiography, but instead, in lieu of that, we proceeded with FFRCT. And this is what the 3D model demonstrated. I didn't display the right coronary and the left circumflex as there was minimal disease, but in the left anterior descending artery, you can see that the distal tip value drops to 0.76. And then further focusing on the left anterior descending artery, the distal tip value, again, was noted to be 0.76. Now, I wanted some more information regarding the ischemic potential of specific lesions that I saw in the CTA, so I utilized the interactive model to identify specific regions of interest and segments where I wanted specific FFRCT values distal to lesions. And as you can see right here, after utilizing the interactive model, distal to these 3 lesions, the values were 0.94, 0.9, and 0.8, suggesting more of a gray zone value drop in FFRCT distal to this lesion right here. The way this CTA and FFRCT was interpreted was the following. The left anterior descending artery demonstrated multiple intermediate stenoses that cumulatively were of borderline hemodynamic significance. So after the CT and FFRCT, the patient was managed medically without the need for invasive coronary angiography. She was initiated on an anti-anginal, a beta blocker, with improvement in her symptoms, and she was also started on a statin. I recently saw her in clinic last week, 6 months follow-up, and the patient remains asymptomatic. So a few teaching points. 1, FFRCT is feasible in obesity. As I had alluded to earlier, patient's BMI was approximately 40 kilograms per meter squared. And we routinely perform CTA and FFRCT in patients with elevated BMIs and are achieving excellent results. Number 2, not all FFRCT less than 0.8 require invasive coronary angiography. And this is a very important point, underscoring the importance of not simply relying on the most distal FFRCT value in clinical decision-making, and also demonstrates the value of utilizing the interactive model in determining FFRCT value across specific ischemic lesions. So if we go back to the interactive model, you can see that the transition to an FFRCT value less than 0.8 is quite distal in this LAD. So it's conceivable that revascularization in patients with these small areas of ischemic myocardium, as determined by FFRCT, may offer no advantage to optimal medical therapy alone. And FFRCT provides the clinician with actionable data. So via shared decision-making, the patient and I decided to proceed with medical therapy, and she's done well at follow-up without any symptoms. And as I alluded to earlier, she safely avoided invasive angiography. So I'll stop there, and hopefully this will spark some nice discussion later on in the talk.
Thank you, Mark. Another interesting case of this interplay, and I think that as Lynn eloquently mentioned, the opportunities of 3-vessel non-biased entire coronary vasculature FFR, but then the importance of understanding the relevance of these data points and how to integrate them into clinical management and decision making. Those 2 cases sort of lumped together. We're going to transition into a different realm, into acute chest pain out of the ED, as well as then Marcus will present a case that's going to focus a little bit around data acquisition and the importance of protocol. So maybe I can open it up to the field or to the people that have joined the webinar as to any questions that may relate to these 2 very specific cases. So I take a moment here to open it to the floor for questions. Maybe I can start. You both highlighted cases where I believe the distal FFR value, I'm trying to remember the distal FFR value Lynn, in your case, if it dropped below 0.75 or not. But we often talk about this this gray zone or borderline zone of FFRCT positivity of 0.75 to 0.80, extrapolated from Bjarne Norgard's data from Denmark. My question is, when you're providing a value and you're looking at the interrogation or the evaluation of lesion-specific ischemia or an actionable stenosis, what threshold, if you then are dealing with a very distal value, worries you, or do you include that in your report? So, for example, Mark, in your case, it dropped to distal to the lesion, let's say 0.78, and then the lowest value 0.75. What do you include the 0.75 anywhere in the report, or do you just simply report the FFRCT to match what would have historically been the measured FFR?
Yeah, so that's a great question. I typically report 1 to 2 centimeters distal to lesions, and that's what I do in my practice.
Okay, and you, Lynn?
So I tend to distal values as well as any values that correlate to an anatomic area of narrowing, and then I try to, for the impression, pull both the anatomic and the FFR values together.
Okay. Anyone else on the phone want to share their experiences or how they practice? I know that I think one important thing is that this highlights, I think, the tremendous opportunity that we as users of FFRCT have with regards to understanding some of these physiological findings that I think have not been interrogated closely. So, for example, we can see a lesion that has a delta FFRCT across it that doesn't take you down below a threshold to suggest lesion-specific ischemia, but then over the remainder of the vessel, we'll see varied degrees of pressure loss. And I think through ADVANCE and through large registries such as ADVANCE, we will be able to learn over the coming years how to determine what, if there is a pathologic threshold of pressure loss over length of a vessel that would determine different appropriate treatment strategies. So a real opportunity to I think learn from these cases and cases in the future. Okay, so there being no other questions from the audience, we'll go on with our next presentation, if we could. Dr. Raff, who has led two of the seminal trials in 2 of the 4, so really half of the seminal trials in the field of cardiac CT out of the emergency department. So we're very lucky to have him join us this morning.
Okay, well, I wanted to share with you kind of a controversial case that illustrates the uptake of a new technology and how controversial and interesting it can be to deal with physicians who are kind of at the cutting edge. And what many of you will find as you adopt new technologies, that obviously there are those who are very eager to take it up and others who are skeptical. So the patient in question is a 44-year-old man who presented to the emergency department with new onset of chest pain over the past week. It was unclear from the story to the emergency department, at least, that this was angina. His EKG and troponin were negative, and the emergency department physician felt that the patient was stable enough for discharge if coronary CT showed no disease or mild disease, which is very common in our practice. So the patient underwent CT, and as you can see, he has a 50 to 70% non-calcified fusiform proximal LAD stenosis. You can see the left lower panel shows about 50% or more stenosis with a lot of non-calcified plaque. And this made the interpreter sufficiently uncomfortable that he said, please do not discharge the patient. Further functional evaluation is requested, and please admit the patient. So the patient did get admitted. And it turned out that the cardiologist who was seeing them was sort of a skeptic, is sort of a skeptic about FFRCT, and he felt that the safest and obvious choice to go to in his experience was a stress echo. Well, the patient ended up doing very well in the sense that he had 10 minutes of exercise without either EKG or echo changes. And the following day, I was confronted with 3 physicians in my office, one of whom was the chief of cardiology, one of whom was the head of the cath lab, and the other of whom was the non-invasive director, all debating what to do with this patient because the chief of the service turned out was rounding, and he was very uncomfortable with the symptoms. The patient's symptoms he felt were very diagnostic, and it didn't, he just didn't feel comfortable sending that patient home with a diagnosis of no ischemia. So together they asked me to do a fractional flow reserve, which I did. And what you see here is that there's a tight correspondence between the position of that lesion and the change of FFR value, rather dramatically shown in this interactive picture. So what we're seeing is that there's a drop to 0.76 right after the lesion, with further drops all the way down to 0.66. Now, we've been talking about how we use this in our practice, and I think most of us feel pretty convinced now that values that drop below 0.75 are certainly concerning, and those below 0.7 are very concerning. And so the end result was that, as I said, I was defending this as valid and important for the patient. So everybody looked forward to the cath because one person was sure it would be negative and the others were sure it would be positive, and it represented sort of a watershed. So here's the cath, and as you can see, there is a proximal fusiform stenosis that looks pretty severe. The chief of service is an interventional cardiologist. He ended up doing an angioplasty and a stent. And I was puzzled. This kind of shook me a little bit. And I thought, how can you have somebody go on the treadmill for 10 minutes with no symptoms and actually have a significant stenosis? Well, as I looked at this, reviewing it for this seminar, I noticed something, that the patient exercised for 10 minutes, but his heart rate only rose to 68% of predicted. And actually, on a detailed basis, I looked at the views of the LAD territory. And at the time of the images, the patient's heart rate was only 86. So by the time they got around to showing the short axis, mid-ventricular, parasternal long axis, the heart rate, although it had been 121, was really lower than 100. So that certainly gives us understanding of why potentially we get this positive FFR and a negative stress echo. So in summary, we have an interesting and controversial case where a patient presents with new onset chest pain that was probably angina. He exercises for 10 minutes and has no symptoms, but his heart rate only reached 68% of predicted. Because of continued concern about the type of symptoms, FFR was definitely positive, and there was a severe stenosis and a PCI was done. So the take-home lesson is that sometimes functional testing, as you know, can be inadequate without our realizing it, and it doesn't always get transmitted to the attending physician who requested the test. FFR tends to be very reproducible, and in this case, I think it was superior to a conventional functional analysis.
Thank you. Thank you for sharing that very interesting case, especially, for someone who comes from a anatomical exclusively background, except for stress EMR, but the importance of, integrating all of the findings and the perhaps the balancing out, I think, of a lot of these patients that may or may not be able to achieve maximal heart rate and perhaps also, I would say, a more efficient approach, since the CT was already done, to be able to perform the FFRCT rather than going through this whole process of the stress echo. My question for you, Gil, is what percentage of patients out of the ED that you're doing cardiac CT on, are you integrating FFRCT? Is it in its early infancy, or are you using this fairly routinely now? Or
we're using it very routinely. Although you have to realize, I actually checked this, and in the past 18 months, we did 1,900 ER CTs and 150 FFR CTs. So our readers, we have 10 readers reading 12 hours a day, 365 days a year, and they are selective. First of all, the true incidence of disease from emergency department patients is low.
right.
And our findings have been that, 25 to 50% stenoses do not represent a positive FFR in the vast majority of cases. So we really are pretty selective about whom we do. The other thing is when you have a very severe lesion, most of the time, about 80% of the time, it's going to be positive. So for greater than 70% stenoses, we also find that it's not as valuable. So what we're really looking at in our practice anyway is the 51 to 70% range as the most productive, with some leniency depending on the type of plaque. Obviously, if it's very ugly looking and worrisome, we would tend to lean towards doing an FFR.
Okay. Thank you, Gil, for that. Really appreciate the case, and I think highlighting some an important role and the clinical utility of FFRCT, as well as I think the exciting opportunity again we have to sort of be more definitive. I know in our experience out of the ED, we modeled our ED practice very much after yours and people like Ricardo's, and we've largely done low-risk patients, although with high sensitivity troponin, that's morphed somewhat. But how do we reduce the 15% or so? The 15% of patients reduce the burden of downstream ischemia testing with nuclear stress testing, which in our system is fairly onerous. It involves the patient coming back and waiting, and they're waiting a certain number of days or being admitted to undergo an inpatient stress test. So I think for these patients, this offers a more rapid and it would appear a viable solution for adjudication of the hemodynamic significance of anatomical lesions. So thank you very much. Next case, and the last case, will be presented by Marcus Scherer. We thought this was a very important case to highlight the take-home message that was discussed by Bjarne at our last webinar, which is the importance of adhering to best practice for cardiac CT acquisition. This is no different. We're not talking about change in acquisition protocol for FFRCT, but just the importance in adhering to the CTA acquisition guidelines as iterated by SCCT just last year. So without further ado, Marcus, if you're ready, we'd love to see your case.
Thanks for having me. This will be even a little bit more controversial case than the last one. I'm going to focus on the impact of nitrate therapy on coronary CTA, and I'm also happy to answer anything else about acquisition techniques later on. This is a 42-year-old woman with a history of a large uncorrected atrial septal defect with World Health Organization Group 1 pulmonary artery hypertension. She's been intolerant to multiple medications for her pulmonary arterial hypertension, and she's had intermittent chest pain with or without exertion with fairly advanced class 3 dyspnea. Now, in 2015, she was referred for a coronary CTA for her recurrent chest pain, and they weren't suspicious of atherosclerosis, but we've known that sometimes she had a very large pulmonary artery, and we've known sometimes about the phenomenon of left main compression with that. Now, when we did this coronary CTA, because her systolic blood pressures were in the 90s, we were asked to withhold nitrate therapy. I even discussed this with the physician, and I was present at the scan. They were concerned about her having severe pulmonary hypertension, and mind you, she was not even on any PDE5 inhibitor to contraindicate nitrate. It was just more so that her blood pressure, her systemic blood pressure, and the severity of her pulmonary hypertension that made people nervous about giving nitrates. So this is her coronary CTA, and you can see the very dilated pulmonary artery in the lower left screen on the curved multiplanary format, and you get a sense that there is a left main stenosis there. Just eyeballing it, it looks close to 50%. Looking at the larger image on the right, you can, when we cross-section that, you can see this pancake effect and this elliptical narrowing of the left main. And so this patient did indeed have left main compression by a dilated pulmonary artery. She had absolutely no coronary atherosclerosis. There wasn't any plaque detected anywhere throughout the entire tree that was interrogated. And when you looked at her diameter stenosis, although on some views, because of its eccentricity and that pancake effect there, it would look sometimes even more than 50%. When you did, it really was in the 25 to 49% range and 37% by QCA. But if you look at it also, the minimal luminal area was quite small. And some people use luminal areas of left main in the past, less than 6 significant, and there's some data to suggest that less than 4.5 millimeters squared is a strong correlate of invasive FFR positivity for left main. And you can see the minimal luminal diameters. So this was done, this patient, this again was a scan that was without nitrate therapy. This was prior to our going live with FFRCT, so this was a demo, and the physicians were not aware of this information, nor did I share it with anyone at the time. This was done before we were approved and went live, just a month or two ahead of time. And you can see that I want you to look at a couple things here. First, when you look at the left main, you can see, that it drops, basically the value would be 1 in the aorta, and it drops to 0.85 in the distal left main. That's a pretty substantial drop, a delta FFRCT of 0.15. And then you can see, as people have talked about, there's this transition, distally. Now, mind you, this is a patient that has absolutely no atherosclerosis, so you have to wonder, is this significant, the 0.74 distally with a 0.15 drop? And of course, no one has a lot of data on FFR values in patients with left main compression from a pulmonary artery. But just keep in mind these values here as I go through this. So in follow-up, this case was discussed with the multidisciplinary team in consideration of cath, maybe even doing an invasive FFR left and potentially doing left main percutaneous coronary intervention, especially given this low minimal luminal area that was discovered. However, like many congenital heart disease patients, she disappeared for a while and was lost to follow-up for nearly a year. She continued to have symptoms of dyspnea and atypical chest pain and returned to the clinic. And then she had when I was told about this case and her symptoms, and keep in mind that old FFRCT that was a demo case that was not documented in the chart, no one really knew about it. And I suggested we do a repeat coronary CTA with nitrate therapy and FFRCT. This is a year later, and this is what we found. So here's her scan a year later with similar projections, and you can see, again, depending on how you look at this, it looks by eyeball, sometimes close to a 50% left main stenosis. You see, again, this pancake effect. Elliptical narrowing, and in this case, this time she had a minimal luminal area of 5.8 millimeters squared and larger minimal luminal diameters. However, keep in mind the stenosis, whether you do it by area or diameters, they were precisely the same as they were without nitrate therapy. In the end, though, with this scan, she had at the level of the stenosis, she had a 49% increase in area and a 30% increase in diameter compared to the study where she did not receive nitroglycerin. And here's the FFRCT, and I'll show you a side-by-side, but I want you to notice this is just with 0.4 milligrams of sublingual. We typically give 0.8. In this case, the patient's blood pressure was systolic blood pressure was 102. I was at the scan just for any concerns of hemodynamic issues, but she tolerated it quite well, just got the usual headache, and she had a normal FFRCT all the way out to the distal vessels. And I want you to notice how many branches you see. It's not only the caliber of the vessels, but look at all the branches you see now. And I also want you to notice when we put the left main pen, it's a much smaller drop now across that lesion. Instead of being 0.85, it's 0.94. And you can generally see how the FFR CT values are larger everywhere. Now, this patient, in light of this information and the atypical nature of the chest pain and the high-risk nature of performing a percutaneous intervention or even a cath with wires in such a patient, we decided to avoid cath and revascularization. This is just, I asked them, HeartFlow assisted with this, and this is a nice demonstration. This is that patient showing the nitrate versus no nitrate scan, and you can see in general how the luminal areas were consistently larger throughout the vessel. And those little spikes where the area increases are branch points. And you can also see how you see more spikes, meaning that more branches are detected. So here's the side-by-side image that I show you, 2015 on the left without nitrate and 2016 on the right with nitrate. And you can see how you may take a total, not only a different interpretation, but a different management approach. You would still wonder, more so on the left image if this patient should be revascularized, especially given that it's ostial left main compared to the image on the right. So what is the impact of nitrate therapy? There's a consistent increase in luminal area and the branches detected. It has an effect on stenoses and vessels that can impact coronary CTA and FFR CTA computational fluid dynamics. And just remember that the more branches being detected, it has an impact on these calculations as well. Nitrates improve FFR CT specificity, and that's Dr. Leipzig's shown that in previous publication derived from de facto data. And FFR CT and invasive FR is really best validated with nitrates. And that's not just for the CT scan. I think we have to encourage our interventional colleagues because a lot of people are doing caths and FFR invasively without nitrate therapy. And if you want to really have an apples-to-apples comparison and do it like it's in the studies, both people should be given nitrates, both at the CT scan and in the cath lab. And of course, in the cath lab, they're giving adenosine, but they're frequently not giving intracoronary nitrates like was done in the trials. So it's really best validated this way. And really, unless it's contraindicated, nitrate therapy should be used for consistency in all cases, whether it's atherosclerotic, congenital, even including coronary anomalies or a case such as this. And we actually prefer to give 0.8 milligrams of nitrate therapy. And there's going to be some emerging data to amplify some of what I've mentioned to even compare, I think, results of using 0.4 milligram versus 0.8, but that remains to be published.
Wonderful, thank you. That's a great discussion and a really important case. I mean, I think that, as you mentioned, both sub-analyses from de facto, but more importantly, the extensive literature as highlighted by Bjarne also last month around the clinical utility or the utility of sublingual nitroglycerin, in particular via spray administration, to help improve all measures of diagnostic performance of coronary CTA as compared to invasive coronary angiography, and then supporting robust FFR CT analysis as a result. So, again, out there, is everyone using 0.8 milligrams, 2 puffs sublingual nitro? Are people using tablet? Are people not using nitro?
Jonathan, I'll tell you, if I could, we would use the spray, but there's they would want us to use a new bottle for every single patient at our facility, and that is cost prohibitive. So we've been using tablets.
Interesting. Yeah, that's something that I've heard from a number of people, which is a bit surprising, or but we face these same challenges when clearly best practice with regards to the pharmacological administration and bioavailability of the nitro is via spray. the other thing that we've really get the fellows and our team and our nurses to be engaged on is the importance of waiting the appropriate time after the administration of nitroglycerin to make sure we optimize the diagnostic performance of cardiac CT. We see sometimes people undertaking the CT acquisition almost immediately following the administration when the vasodilatory effects of the nitroglycerin haven't taken effect yet.
Yeah, I agree with that. We typically, what we do is we do a test bolus method, and we give it right before the test bolus. Usually about 5 minutes goes by, but we do a double check too, in the sense that we always go have the technologist go back and ask the patient to raise their tongue to make sure it's dissolved. A lot of them have dry mouths, and there's no point in scanning them when they have 2 sublingual solid tablets remaining under their tongue.
Right. Excellent. Any comments or questions from the audience? Okay. Well, I want to thank all of the speakers. I want to thank HeartFlow again for the forum and the opportunity to share our cases as well as engage in discussion. I hope you all found this of interest, and I think from take-home points, the opportunities with the new reporting structure I think are meaningful, as we saw in the first 2 cases, the opportunities to focus at least initially on actionable lesions to determine whether or not, in fact, there is lesion-specific ischemia, but still having the additional information of distal lowest FFRCT values available. We also heard from Gil the new application of FFRCT for acute chest pain and the opportunities there to adjudicate the hemodynamic significance of intermediate lesions in particular, and potentially reduce the burden and improve efficiency, managing these patients by reducing the need for downstream repeated testing, either with ionizing radiation or otherwise. And then finally, I think a very important point, Marcus, the case aside from compression of the main pulmonary artery, this is a very interesting, we could talk probably for an hour on, how to manage or the meaning of such findings. But beyond that, the importance of best practice for coronary CT assessment. I've heard, I think as the technology's improved, I've seen a number of sites, again, slide away from that. We've tried to emphasize through the SCCT guidelines last fall that regardless of the scan platform, best practice is best practice for cardiac CT, and best practice involves the utilization of nitroglycerin. I think that the benefits of nitroglycerin are now amplified because we're no longer just looking at the presence or absence of anatomical stenosis, but trying to use these data to to inform computational analysis to answer many, many more questions beyond the historical question of diameter reduction. So thank you again all for the opportunity and for taking the time to present and share your work. And thank you all for joining, and look forward to our next webinar in late April. Thank you again.